So in this video we shall be discussing a few important points of your thyroid carcinoma. So we divide this into two parts. We shall first discuss your salient features of the various types of your thyroid carcinoma, that is your papillary carcinoma, follicular carcinoma, medullary carcinoma and your anaplastic carcinoma. Followed by that we shall be discussing in detail regarding your follow-up of your differentiated thyroid carcinoma. So first regarding your papillary carcinoma. So papillary carcinoma is your most common type of thyroid carcinoma. It is common in females compared to your males. It has a peak incidence in your third to fifth decade of life. It has the propensity to move towards your lymph node. So there would be a lymph node involvement in your papillary carcinoma. So if you get a clinical scenario where you have a swelling in the neck along with your lymph node involvement, it is likely to be a papillary carcinoma. The distant mets is quite uncommon in case of your papillary carcinoma. They have a high rate of your occult micrometastasis. Now papillary microcarcinoma are defined as lesions less than 1 centimeter. They have an excellent prognosis, and the histopathology consists of your complex branching papillae with your pseudo-inclusion, nuclear grooving and your samoma body. So if you look over here in your image, so this is the HP image of your papillary carcinoma having your samoma bodies and orphan Annie eye nuclei, which is one of the characteristics seen in your papillary carcinoma. So this is your orphan Annie nuclei, that is C. Now next we have is your follicular carcinoma. Now this is much more common in your elderly. These are differentiated only on your histopathology. So a FNEC will not be able to differentiate a follicular adenoma and a follicular carcinoma. Now they are prone to have your blood-borne metastasis, and they are usually seen in patients having a history of long-standing goiter. Now these are your few clinical points which will help you to clinch your diagnosis of follicular carcinoma in your clinical scenario. An elderly patient having a blood-borne metastasis and a history of long-standing goiter. Then they have an Hurtle cell variant, which usually has your poor prognosis and has presence of your oxyphilic cells. Then we have your anaplastic thyroid carcinoma. So there is a dedifferentiation of your papillary or your poorly differentiated carcinoma. So they have your rapid growth, visceral invasion and distant metastasis. On HP you will be able to find your giant and multinucleate cells. Now there are sheet of cells with marked heterogeneity. Now there is a limited role of radiotherapy and chemotherapy in anaplastic thyroid carcinoma. So usually you would basically needing a tracheostomy if your patient presents with your signs of airway obstruction in order to relieve the obstruction immediately. Then we have your medullary thyroid carcinoma. So in medullary thyroid carcinoma they arise from your parafollicular cells. Now this is your characteristics of your medullary carcinoma, that is your amyloid stroma. Then they have the calcitonin levels and the CE levels elevated in medullary thyroid carcinoma. Now diarrhea is seen in 30% and this has been attributed to your 5-hydroxytryptamine. Now they are familial in around 10 to 20% of the cases and they are associated with your MEN syndrome. Now lymph node involvement is seen in around 50 to 60% of the patient, and the treatment would include your bilateral neck dissection and total thyroidectomy. So these are your few important points with respect to your medullary thyroid carcinoma. Now coming down to the specific differentiated thyroid carcinoma, that is your papillary and follicular thyroid carcinoma, the treatment usually is the total thyroidectomy. Now in case of a low risk, a radioiodine therapy is not required compared to the high risk where you would require a radioiodine therapy. So what is the rationale for the radioiodine therapy? Now this eliminates any normal thyroid tissue that is left after surgery, hence simplifying the subsequent detection of your residual or your recurrent tumor tissues. Now this also destroys your occult microscopic foci of your neoplastic cells within the thyroid remnant, and they treat your residual tumors. Now the timing for ablation, it is usually done at 6 weeks post surgery, where we make the thyroid depleted for 6 weeks, and if we want to do this process early, then it can be done if we use a recombinant TSH levels. Now regarding your prognostic factors for your thyroid carcinoma, the various prognostic factors include your age, metastasis, extrathyroidal spread, size, the lymph node, and the molecular and the tumor marker like your VEGF and P53. So these are your various prognostic factors that are associated with your thyroid carcinoma. Now regarding your risk classification, it can be classified into your 3 risks, that is your low, intermediate and high risk as per your American Thyroid Association risk classification. So it is done on the basis of your local invasion, cervical node, distant metastasis, post-op uptake scan, completeness of excision, histology and thyroglobinemia after ablation. Now in case of your low risk, there won't be any invasion, no cervical lymph node involvement, no distant metastasis, no post-op scan, complete excision is done, a non-aggressive histology, and there is no thyroglobinemia found after ablation. Whereas in case of your intermediate risk, we have a microscopic local invasion, involvement of your cervical lymph node, no distant metastasis. Now post-op uptake scan is confined to your thyroid bed. Now the excision is complete, has an aggressive histological behavior and no rise of your thyroglobulin after ablation. Whereas in case of your high risk, we have your macroscopic local invasion, involvement of your cervical lymph node, presence of distant meds, the post-op uptake scan is seen even outside your thyroid bed, the completeness of excision remains incomplete, histology is aggressive, and you have your thyroglobinemia after ablation present in case of your high risk disease. Now what are your various follow-up regimens of your differentiated thyroid carcinoma? So for your uptake scan, you do it twice in your 5 years. For your clinical examination, you would do it 3 monthly for 3 years. The thyroid function tests are done for 3 months, 6 months and annually, and you have your thyroglobulin assay, which is done at interval of 6 months, 12 months, 24 months, 36 months, 48 months and your 60 months. Then regarding your recurrence, so if there is a raised serum thyroglobulin assay, that is more than 5 nanogram per ml with T4 supplementation and more than 10 nanogram ml without T4 supplementation, then you would go for a radioiodine uptake scan for the ablation. Now there is an entity when there would be a radioactive uptake scan negative, but there is a recurrence. So why would it occur? Now this is occurring because of your dedifferentiation of cancer into your more anaplastic form. So please remember that your negative radioactive iodine uptake recurrence is associated because of your dedifferentiation of your cancer into your more anaplastic form. So in this case, we need to go for your redifferentiation therapy. Now the redifferentiation therapy would include your retinoid therapy, FAX8 PPR gamma agonist and selumetinib. Right. So these are your few important points with respect to your management of your differentiated thyroid carcinoma, and the last point that we shall discuss is regarding your molecular targets. So remember your name of sorafenib, which is your tyrosine kinase inhibitor, and your levatinib, which have been used in your differentiated thyroid carcinomas. So the basic rule in management of any cancer or thyroid carcinoma would be a proper clinical examination and history taking, followed by your ultrasonographic examination, followed by your fine needle aspiration cytology, and then on the basis of that you would proceed for the surgery, and then you would go for a radioiodine scan uptake on the basis of the risk stratification. It is usually needed for your high and your intermediate risk. So this is all about your thyroid carcinoma. Thank you.